So moving on, let's take a look at frostbite. So like some of the other injuries we've talked about, frostbite is a localized cold injury, usually affecting the fingers and toes of patients. The difference between frostbite and, say, trench foot is that frostbite is considered a freezing injury. The tissue completely freezes. So before we get to frozen fingers, let's have a look at what leads up to frostbite. First of all, who gets it? Well, for the most part, it's people who have an altered LOC. In a Canadian study, 53% of all frostbite patients in Edmonton had ETOH on board, and another 16% had some degree of mental health psychosis. Homelessness and a history of drug use are also huge risk factors for frostbite. We can also see frostbite in the adventure athlete population. These are people who head to the cold for a hike, a fishing trip, biathlon, etc., and are either underprepared or push themselves too far and end up with frostbitten toes. So we're normally generating heat and using our bloodstream to circulate it around our body. Our skin temperature normally sits at about 30 degrees Celsius, and that's in our peripherals. As we get exposed to the cold, our body naturally starts to preserve the core temperature, so vasoconstriction happens, pulling that warm blood back. When the tissue starts to get around 15 degrees Celsius, we get maximum vasoconstriction, and that's typically when the patient will start to experience some severe pain. This should be the first warning sign to stop and warm themselves up. If we get much colder, the body will try and prevent tissue damage by starting Hunting's response, which is 5 to 10 minutes of vasodilation. And this is going to help bring blood back to the tissues. If we let our skin get cooler, we'll start to hit that numbness phase, right around the 7 degrees Celsius. This is common in athletes. They work through the pain and they think they're doing better. Unfortunately, if left alone and the tissue gets to 0 degrees, we're starting to hit frostbite levels of injury. So frostbite has 3 phases: pre-freeze, freeze-thaw, and vascular stasis. Pre-freeze, blood and cellular fluid starts to get thick, making it difficult to oxygenate and perfuse. So we start to get tissue ischemia. The microvasculature completely constricts, furthering the ischemia. Finally, we start to get some leakage of the intracellular fluid through that cell wall, which can lead to some small ice crystals starting to form. The freeze-thaw phase occurs when this leakage of plasma begins to form ice crystals. These ice crystals will pull more fluid from the other cells next to it due to their increased oncotic pressure. And this can damage the cell walls even further, making more leaking, which will cause the crystals to get bigger. As the crystals start to get bigger, they'll also start to compress arteries, veins, and other tissue, leading to an increase in the ischemia. Eventually, the tissue cells will start to denaturate and just collapse. Finally, we have vascular stasis. This phase occurs usually during the rewarming. At that junction between injured and non-injured tissue, we get this weird mix of vasoconstriction trying to isolate the cold blood and vasodilation trying to feed the ischemic tissue. The problem is the blood is still cold and thick, and during this phase, lots of little microthrombi start to form. These thrombi can travel to other tissues, furthering the ischemic injury. When we're evaluating frostbite, there's a few important things to look at. First, skin that has frostbite will be pale, waxy, depending on its stage and duration, even black. You may see blisters. This is a sign of that freeze-thaw phase, and that can help show the depth of tissue injury. If the blisters have clear fluid, it's likely still superficial, and it hasn't frozen all the way to the dermis. If there are hemorrhagic blisters, that shows that freezing has occurred into or below the dermis. Often blisters may not show themselves until after rewarming, sometimes 24 hours later. Also, watch for cyanosis. This can be helpful in assessing for risk of amputation. Frostbite can be divided into grades, with grade 1 having no chance of amputation and grade 4 having a high risk of amputation. The problem is the grade is assessed after rewarming, so pre-hospitally this isn't overly helpful. See any cyanosis in the extremities? Best to assume the worst. Treatment for frostbite is actually more complicated than you'd think. There's the obvious one: warm them up. 30 minutes in warm water if possible, circulating if you can, and try and get that water 38 to 40 degrees Celsius. You can add some isopropyl alcohol to the water to help sterilize the skin. That's kind of hard to do in an ambulance, so pre-hospitally our job is likely just to get them moving. Luckily, Frozen tissues won't become ischemic until they're rewarmed, so transport is our big priority. Once in the hospital, there's a few more options. Ibuprofen 200 milligrams to help with the pain and stop some of that microthrombi forming, along with aloe vera covered bandages. For grade 2 to 3 frostbite, an iloprost infusion, it's a vasodilator that has some anticoagulant effects, is started. Grade 4, on top of the other treatments, will also get alteplase and enoxaparin to stop the further ischemia from blood clots.